Thanks for the introduction. I'm here to show the work of Jose Pineda, who is our imaging engineer, and I'm here on behalf of him and of course of the whole team. Well, it has already been told, VIM lesion or VIM DBS improve medical refractory essential tremor. The mechanism by what it occurs is not clear, but it could be related to the impact on the so-called tremor network, which involves the cerebello-thalamo-cortical pathway. This is our sample. We included 24 patients, mainly male, right-handed, and we treated the left hand in order to improve the dominant hand. These are our clinical results in terms of CRST improvement. These are similar to the available literature. There was an improvement of up to the 80% for the hand tremor, the treated hand tremor, and for daily life activities about 76%. And well, going into the imaging analysis, we first made a lesion segmentation. Here you can see the lesion at 24 hours after procedure and at 3 months. Oops. Okay, I can see it. Okay, good. And you see how the lesion decreases its volume up to the 70%, while the core of the lesion remains stable in terms of laterality and antero-posterior axis. And therefore, this decrease in the volume is mainly related to the edema. And then we did the tractography analysis. We reconstructed 3 anatomical pathways who run through the VIM or nearby the VIM, which are the cerebello-thalamic tract. We took as region seats the dentate nucleus, the superior cerebellar peduncle, the thalamus itself, and the precentral gyrus. We also reconstructed the corticospinal tract and the medial lemniscus. These are the initial results of DTI within the lesion borders. We analyzed 4 DTI measures, and what we saw was that there was a decrease in functional and fractional anisotropy and axial diffusivity from baseline to 3 months after treatment within the lesion borders, which makes sense because we have made a lesion there. This is the impact on the treated brain site on the cerebello-thalamic tract. What we see is that there is a reduction in fractional anisotropy within the site of the lesion, as well as a reduction in the white matter just below the motor cortex. In addition, there is an increase in mean diffusivity and radial diffusivity, also in the white matter below the motor cortex. Again, it is me? Or, no, well, there was a correlation between the changes in the cerebello-thalamic tract and the clinical outcome, especially for the mean diffusivity. It was related to the improvement in the treated hand. And we also analyzed what happened with the neighboring tracts, the corticospinal tract and the medial lemniscus, and we saw that there was an impact in the neighboring lesion in both, and there was also a decrease in functional anisotropy along the corticospinal tract. However, it was not related to clinical presentation because we have had no motor impairment in any patient. There was no impact in the non-treated, as expected, in the non-treated brain site. So we also analyzed the tractography of patients who develop ataxia or instability. I wouldn't say ataxia because at 3 months only 1 patient had objective ataxia. 6 of these patients only have a feeling of subjective instability. And what we saw is that there was a correlation between the impact on the cerebello-thalamic tract and the presentation of instability. It was the same for the sensory symptoms. Patients who develop sensory disturbances had a higher impact on the medial lemniscus, also as expected. Therefore, the conclusions are that, well, we perform overall satisfactory VIM HIFU in 24 essential tremor patients. The topography of the lesions are are similar to that have been reported so far. We did not find any correlation with the topography to the clinical effect, which was surprising. We have mapped the tracts, and we have seen that the impact on the cerebello-thalamic tract is related to the improvement of tremor, but it could be also related to the presentation of ataxia. So we must impact on this tract, but be careful with the side effects. And that's all.
Thank you very much. And this presentation is open for questions.
Maybe I missed it, but when I was looking at your data, I saw the difference in the sensory changes in your last data slide, but maybe I misunderstood it. It didn't seem like there was. Can we bring his talk back up? Because is that possible or no? Because if you look at your last, the last slide before the conclusions.
The next one?
Yeah. This one.
Yeah.
So between the ataxia patients and the ones that didn't have ataxia, you're saying there's a difference?
Yeah. And it was the same for the patients who develop paresthesias. They have a higher impact on the medial lemniscus, but it is not shown in the figure. It's only shown in the table. The figure is only for the ataxia patients. So that I wouldn't say the ataxic patients. I would say the patients who felt instability.
Okay. I mean, maybe I'm misreading it then. I'm just not seeing, your numbers don't look all that different between your two groups. That's all I'm saying. So.
Now, does your imaging include cortical bulbar? And the question is, does that account, is there any correlation with dysarthria, which does occur in some of those patients?
No. As long as I remember, we only have, we didn't have dysarthria. We had one patient who had a decreased verbal fluency or fluency of speech, and you cannot correlate to. Maybe we could find it if we had more patients with dysarthria. Maybe, probably, in fact, but we don't have enough patients developing dysarthria.
Okay, thank you very much.
Thank you.